Hey, what's
دكتور جون.
Yes. Ahmed, how are you? Okay, I can see you there on the screen, right? Let me get off that spotlight. Hello, how you doing?
Hello, Mr. John.
Hi, Ahmed, how you doing? You doing okay?
Yes, just a minute. We will transfer to another lab.
Okay, where?
Just a minute.
How about the podium? You're gonna test the podium, the microphone on the podium.
Okay.
Hello,
Hey, Ipe.
John.
Ipe, how you been?
John, I'm good. I want to do a good virtual background. I'm trying for a good virtual background.
Okay, hold on. Hold on. Let me get on here. Okay, yeah, well, let's get you a good background. Okay, where are you, Ipe?
Yeah, I got it. I think I got it done. Let me see.
Okay, go ahead. Go to your there you go. Okay, there you go. Is that what you want?
Something with photographs of cystonostomy and stuff. So
Yeah, well, just pick out a photo from your desktop and put it there. Go to the virtual. Go to the choose virtual background.
yeah.
Okay, and then go to the plus. It has a plus next to virtual background video filters. There's a plus. When you click
what
that,
if
when you
I know,
click
but
that
what if-
plus, you'll add an image from your desktop.
it's asking allow Zoom to access your photos from device menu. So I need to probably.
You just need to upload a picture.
Huh?
You need to upload a picture to your Zoom background, to your virtual background.
Yeah. So I need to have the privacies for Zoom. I'll have to go to the settings, privacy, and allow Zoom to probably, do something.
No, it's not that complicated. Go to the video option on the panel at the bottom, right? You open your virtual background, choose virtual background, open that up. Did you open it up?
Yeah, I opened it up.
Okay, you see it has a plus. You see the plus on the right-hand side?
Yeah, I know. But what happens is this is an iPad, and
Yeah.
it is not allowing me to just add it because it's saying allow Zoom to to access photos from the desktop.
That I don't know. I don't.
Yeah, that's so that. So what I'll do is I'll go to the settings and I go to Zoom now. I'll go to Zoom.
Okay.
And I'll see if Zoom can.
I'm sure you can figure it out.
June, how are you?
Good. How are you?
I'm fine. We are on now. Okay. Can we run a test for the presentation?
Yeah, sure. Sure. Go ahead. Yeah, we got 10 minutes.
Okay. مسختها الحين هنا.
As you can see, we're going to have some challenges.
Okay. I will do screen sharing. Okay.
Okay.
You see my screen?
Yes.
Okay, good. You see the presentation?
I don't, I just see the screen. I don't see any presentation yet.
Okay, I will stop screen sharing and share again.
This is great. Learn how to do this 10 minutes before the start. That's pressure. Try it again. Try it again.
Ready, okay.
Okay. Okay. There you go. You got it. You got it. Okay. At the very bottom, you can make it bigger. There you go. You got the right idea. There you go. Perfect. Okay. You got it. You got it.
Now everything good?
Yeah, it's good. It's good. And he can make the screen bigger if he wants. It's up to him. You know, the next slide, whatever he wants to do. He controls the options. Okay.
كيف اكبر على الشاشه كامل هذا الحين؟ خلاص يبغى هنا بس الشيء خلاه اوكي it's good in the slides it's good.
Yeah, that's good.
This video.
That's good. That's good.
Let's check.
That's good.
John,
Yes,
the video is working.
it's working. The slides are working.
Good. There is video.
including the.
Okay, no videos. No videos.
This is video now.
No. Okay, but it's going to crash because you don't have a very strong bandwidth.
Okay.
Okay, don't expect the videos to work. You can try them, but don't expect them to work.
Now it's working or not?
Okay, well, you may get lucky, but it's probably going to stop.
You see it now, the video or no?
Yeah, it's okay.
It's okay now.
Yeah, it's okay. It's not good quality.
Now you hear me or no?
Yeah, I can hear you. Can you hear me? Okay, it's very possible, Ahmed.
So we're good to start. What do you think, John? John,
Yes.
it's good to start. What do you
Okay,
think?
I'm in chat. Okay, chat. Okay, what do you want to tell me? You want to tell me something? I'm in chat now.
You hear me or no?
This is the best way to communicate with me, through chat, okay?
Okay.
Or WhatsApp is all good too. WhatsApp is even better. But it's very possible I'll say, stop the video. It's not working, okay?
The video is not working.
Do you hear what I say?
Yes, yes. The video is not
Okay,
working.
if the video does not work, I'm going to say, stop the video, please. It's not working.
So we can see only the slide. The video is not working. John,
Hey, you know what? No video. No video. Okay? No video.
so we do only slides. The
No,
video-
only slides. Like I said yesterday, no video.
you keep
No video.
the- Okay.
No video.
Now you hear me clearly or no, John?
Okay? No video.
Okay,
We
you hear me
don't,
clearly.
yeah, we don't have the bandwidth. We don't have the power.
Okay, now, but now I do test for the microphone. Do you hear me clearly?
Yeah. It's
Or no?
better we don't do video.
Okay, I understand you.
Okay.
How is the sound now?
Yeah, okay. The sound is okay.
Is it good, clear?
It's okay.
Okay, better than nothing.
Okay, now it's important that I communicate with you. I may have to say the sound is bad. Fix the microphone. Get closer to the microphone. Do you know what I mean? Okay? Okay?
I will keep in the background and communicate with you on WhatsApp.
Yeah, I may. Yeah, good. I may say I can't hear. The sound is not good.
Okay, that will be great.
I may tell you that in WhatsApp.
Okay.
Okay. I can hear you okay now. Yeah, I hear you now.
John, now you send the link, the same link we can use to enter. We have another panelist and moderators. They can enter from Professor Paolo. He want to enter from Italy. He want to be a panelist. I sent him the same link or get another link?
Send them the link that works.
The same link.
They're all over the internet. And the same link I sent you this morning. Oh, mute, you motherfucker. Hey, Maria.
We are on, John. We are on the. We are on.
No, we have not started yet. We have not started yet.
In the auditorium now, we are starting with it's a broadcasting auditorium now.
No. Okay, who is the first speaker?
Dr. Abdullah Usta, Professor Abdullah Usta is here.
Okay, who is going to introduce them? Who is the host?
The host, the moderator, Dr. Muhammad Shamsuddin and Dr. Badr.
I need to speak to the host. Who is going to be the host to introduce the speakers?
Doctor, we have one colleague, Prof. Paolo Berrini from Italy. We want to, yes.
We are not starting yet.
Yes, okay. Huh?
We are starting in 2 minutes, okay? Is that okay?
Okay.
Okay, who is the host? Who do I introduce?
Yeah, Dr. Muhammad Shamsuddin, neurosurgeon, and Dr. Ahmed Al-Barida on Carotid.
I'm sorry, Ahmed?
Yes, sir.
Yeah. Ahmed, you need to be the host. Or someone needs to be.
You, Dr. Muhammad Shamsuddin, he's speaking to you now, okay?
Okay, who do I introduce?
Yes, doctor.
Okay, who do I introduce as the host? Who do I introduce as the host?
Yes.
Okay, we're not going to start until I'm ready, okay? Okay, I need to know the host. Oh, man.
Hello, I am Dr. Ahmed Al-Barid, the host.
Okay, okay, Dr. What?
Dr. Ahmed.
Okay, Dr. Ahmed, I'm going to introduce you, okay?
Clinical oncologist, consultant clinical oncologist.
Okay, Dr. Ahmed, right? Okay. Okay, I need. Okay. I need to speak to Ahmed. Ahmed.
Yes, you need the speakers.
Oh, okay. Okay, your name, sir?
My name is Ahmed, Dr. Ahmed.
Okay, Ahmed, I'm going to introduce you, okay?
Okay.
And then you introduce the speaker, okay?
Yes, I will introduce the speaker. Okay.
Yeah, please. Yes, please. Okay, we're gonna, you ready to start?
Okay, I will start with the first speaker.
No, 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 no. I start.
You will start. Okay.
I will tell you when we start, okay?
Okay, thank you.
Okay, just 1 minute. I'll tell you. Just a minute. Let me get ready. Okay. Okay. We're going to start in 1 minute, okay? Ahmed? Ahmed? Okay.
John.
Okay, just 1 minute. 1 minute, okay?
Okay, we start the introduction of Dr. Allah.
Okay, we're going to start in 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. Today we have the pleasure of hosting the Yemen Neurosurgical Conference, and I'll let Ahmed introduce the first speaker. Welcome, Ahmed.
Welcome. Our first speaker will be Professor Dr. Abdullah. He is a professor of neurosurgery. His lecture will be about the cystostomy, anatomy, physiology, radiology, and surgical techniques. Please, Dr. Abdullah, you can start your lecture. Professor Abdullah Al-Usta. Where is Professor Abdullah Al-Usta?
Okay, we're ready.
I'm sorry, the first lecture will be by Professor Dr. Abdullah Al-Usta about the skull-based surgery. Okay.
Okay, very good.
Okay, thank you. Here you are.
We're a little disorganized, but we'll get it together. Is the first speaker ready yet? We can always edit this. Ahmed, are we on?
Yes, yes.
Who was the first speaker? There's no one.
I am Dr. My presentation will be about skull-based surgery, philosophy before surgery, after surgery. Just now, let us just to, okay.
Ahmed, Ahmed, are you there?
Yes, I'm here. I'm here.
Okay, is someone going to present?
Okay, just
Now the bargain.
You're working on it. You're working on it, right? Okay,
just
here we
now.
go. Okay, yes. Okay, very good. Ready?
So this is what you can see is about the skull-based tumor. And this picture is just to show you what we are seeing inside after going with the approach to the skull-based surgery. It is there is a number just to show you the optics, the vascular, the posterior cerebral artery, and to show you the approaches from inside that we are going in. Here we can see the philosophy of neurosurgery is just to do your work from a small hole with a good light, good hands, and good mind. You can achieve your work from this small hole. Just you will go and you will face these structures. From where among these structures you can take the tumor. The philosophy of neurosurgery is not only to take the tumor and to face the pathology. The philosophy is to maintain and to keep these neurovascular and the vital structures. As you can see here, if you go inside, you know that every tumor in the skull base has its own approach and it should have its own preparation. And the main is to maintain and to keep these neurovascular structures. Here we are having a video where you can see in this video, we can see the structures, how we can maintain them, and how we can keep them. This is the carotid artery, and this video was taken after removing her large meningiomas, which was extending beyond these structures. Here you can see the internal carotid arteries and this bifurcation. And here you can see also how you can go through them lateral to the optics, lateral to the carotid arteries, between the branches, anterior cerebral artery, middle cerebral artery. You can see down there the brainstem also, from where you can go through the sylvian fissure. Fissure, you know, is the most main anterior skull base, and it is very necessary to know the anatomical of this in details. Here you can see the branches. Coming to the, just a minute, because that doesn't show IT. Where is IT? So you can see here, this is the infundibulum stalk, which is a very important structure to see after surgery and to maintain it. Here you can see also by elevating the optic nerve. Here you can see the carotid artery coming out of the cavernous sinus. And if you can see here the nerves in the posterior fossa that's going to the cavernous sinus also, you can expose the nerve down also by playing with the arachnoid very nicely. You know, the main thing in skull-based surgery is just to be between the bone and the arachnoid. You can see here the basilar artery also, where you can see it from the same approach, and you can see the pontine vessels. This is the middle cerebral artery through the sylvian fissure, which you can see its long approach from the carotid artery is coming to the end of the middle cerebral artery and its final branches. With that very interesting things that you can see here also, the branches of the carotid artery, the infundibulum stalk, and also you can hear the very interesting, the early coming middle cerebral artery from the carotid artery. You can see here also, we can go through the system, through the arachnoid from the same approach after removing the tumors. You can see also the basilar artery. This is basilar artery, and cerebral artery. You can also go to the tip of basilar artery and its branches and the connector with the posterior cerebral artery going to the carotid. This is the basilar tip also. The main thing is just by doing surgery to the anterior cranial space is just to It's just to, you can go also to the pyramidsencephalic cister and to see there the pyramidsencephalic structures. And these are the nerves that going also up by exposing the vessels, and to be also careful and to do any decompression there. This picture was taken after complete excising a very large tumor, as we will see later on after video. Here you can see also, this is the infundibulum stalk going toward the diaphragma sella. And here also you can see coming out of the midbrain and going there up, just going to the diaphragma sella. And this is the important thing, just to say the brainstem that after completing the surgery with a clean blood, now you will see this also the infundibulum stalk, which is very important structure to be care about during the skull-base, anterior skull-base surgery. This is extension. Here, by removing little bit traction, you can see the infundibulum stalk going. It's right away toward the diaphragma sella. This is a posterior CP angle where you can see all these structures, the cranial nerves from 7 to 11, and this is after separating the trigeminal nerve from the compressing vascular structures. This is the picture that you will see in the CB angle, where you need to care about all of these nerves during surgery of this place. Now coming to the skull base of large tumor that extending outside of the skull, you can see the tumor by removing this swab coming out of the nose and start bleeding, coming out of the hard palate. You can see the radiology extending everywhere up to the clivus, up to the skull base, coming out of the nose, coming out of the mouth. And you will see here during surgery, by using transmaxillary approach, tumor can be exposed, can be taken out completely. Fixation of the maxilla can be done. And you can see here after surgery that the patient is all right, moving his mouth freely without any difficulties. You can see here, this is a large tumor. So another tumor for the patient, which is very large. And you can see here, while preparing the surgery, coming out also nose. And you'll see here from the ear, sorry. And you can see here radiology, it is extended into the skull base, distracting the bone.
We're having Wi-Fi difficulties, just hang in there. Okay, slow down in Wi-Fi. Well, he probably fell, hang in there. He probably fell off due to the Wi-Fi, but he'll come back. Just wait. And we'll just have to keep our fingers crossed for the rest of the transmission. But we knew what we were getting into. We knew it would be iffy type of connections. So hopefully it'll work out okay. Ahmed, please encourage the speaker to come back in. Yeah, I'll text you. Hang in there, we'll get it going.
Just continue. There is some little bit technical problem.
Okay, let's work it out. Keep working on it.
Okay.
Okay.
Okay, here we are.
It's okay.
It's not working. Mhm. this is also the anterior skull base, which you can see that. Sorry for this little bit technical problem. Working or no?
Okay, I don't know if the sound, go ahead, test the sound again. I can't hear you very well.
This is some less technical problem. There is also such like a tumor with a very large anterior skull base, where you can see that the tumor compressing the anterior cerebral artery. The post-op surgery just showed that the tumor was excising completely with the normal and neurovascular structure later on become okay. This is another case also of a tumor which is completely excised of the first one. This is another case of the skull-base surgery, which shows that you cannot see in the pre-operative image the infundibulum stalk, but after surgery, you can see the infundibulum stalk very clearly, as you can see here. The optics apparatus also is showing clearly. Now you can see also some another anterior skull base surgery which cross the structures into the brainstem, compressing the brainstem. After surgery, you can see that the carotid and the optics also is completely free from the tumor. You can see also another very large and huge anterior skull base tumor that you cannot identify the infundibulum stalk or even the optics extending into the sella to the diaphragm, where you can say post-operative that the infundibulum stalk was dissected freely of the tumor. Such like a tumor rising from the sella into the suprasellar. Just a minute. You can see here that you cannot see the infundibulum stalk, but after surgery, you can see the infundibulum stalk very clearly going into the diaphragma sella. You can see here also the tumors inside the third ventricle, which was talking by the translamina terminalis approach, and it shows post-operative that all the anatomical structures is clearly visible.
Dr. Abdullah, still 2 minutes.
Here is also very large tumor from the clinoid part, and post-operative you can see that the tumor completely was excised and the carotid were dissected out of the tumor. This is another case, the same thing. You can find the optic apparatus and you can see the infundibulum stalk very clearly visible. The same thing, this is a very large pituitary tumor. Internally, this tumor was taken completely out, and you can see all the structures, which is very important, clearly returned to its normal anatomical positions. This is the tumor also where the vessels are going inside the tumor. It was dissected freely, and you can see the carotid and the middle cerebral artery and anterior cerebral artery visible. Such like tumor also, the same what we are looking during tumor excision is how to keep and maintain.
Dr. Abdullah,
Yes.
still 2 minutes.
Okay, thank you. There is a technical problem in this. You can see also this is a very large tumor in the suprasellar, and the image after that, the same thing you can see very large clivus and cellular tumor, and post-operative the anatomy of the important structures is there. Here also you can see very large tumor through translucent fissure. The anatomical structure was dissected away of the tumor. Here also going to the sella, and you can see post-operative good images for that. The same thing in the posterior fossa, a very large tumor compressing the brainstem, and you see how the brainstem came back to its normal position after surgery. The same thing with the huge, very large tumor, and you can say it's post-operative. Same thing also the middle fossa and the posterior fossa tumor, which was taken through the suboccipital retromastoid approach. The same thing, you can see a very large tumor in the posterior fossa, which was dissected, and the post-operative image.
Dr. Abdullah,
Yes. Okay,
conclusion,
one
please.
minute. This is a very large posterior fossa surgery, CP angle, and you can see
Still 2
here
minutes.
the patient post-operative has very mild facial palsy. And this is another case with the patient post-surgery. You can see the patient has no facial palsy because of the complete dissection of
Still
the
more
facial
time,
nerve.
Dr. Abdullah, because we have guests from outside.
Okay, 2 to 3, less than 1 minute. This is another case of epidermoid, and this is another case of right side epidermoid going to the ciliary region, which was completely taken from the posterior fossa approach. This is another case also. You can see this is a very large tumor pre and post, and this is a very large tumor to the brainstem, which was taken through the same approach. This is a peripheral meningioma, was taken a small residual hard part was leaving just around the basilar artery. And this is the foramen magnum meningioma pre and post, the same very large clivus and the foramen magnum meningioma, which was taken through a very good approach. Such like patient which was died before surgery, like this one, he came to us very late. He died before surgery and more towards skull base. Thank you.
Thank you, Dr. Abdullah. And we have 1 minute for one question for Dr. Abdullah, or two.
Okay, thank you, Dr. Abdullah. You didn't mention for us what the type of
That is angiofibroma. Yes.
Thank you. Thank you so much.
Thank you.
Any other question? Thank you, Dr. Abdullah. Thank you.
Thank you too much. And sorry for such technical problem.
Okay. Our next speaker will be Professor Laib Chirian from Inc. About histological, about cystostomy, anatomy, physiology, and radiology and surgical technique. Professor Laib, you can start your lecture.
Yeah, it's an honor to be here for the Yemeni's Neurosurgical Conference. Ahmed, thank you very much for calling me for this. All my friends, I can see Victor, John, and everybody there. And see, during, I'm in the lecture, Ato. Hello, can you hear me?
Yes, we can hear you.
Yeah, so I saw the previous lecture for Dr. Abdullah. It's a fantastic lecture. I was enjoying the lecture. Excellent work being done in Yemen. I'm proud of you guys. So, well, I'll go into trauma, how we use skull base and vascular for trauma. That's what I'm going to show you guys. So let me start off. You can see my screen?
Yes.
You can see my screen?
Yes.
Okay. So this is a common scenario all over the world. In fact, the most common scenario, actually, more than any tumors, more than any aneurysms, the most common scenario that you will see is trauma, and this is an acute subdural hematoma. This surgeon is removing the acute subdural hematoma, and this is what happens. And I'm sure this is a pretty common scenario too. I'm sure all of you would have seen this. How do you avoid this? That would be my talk. Instead of just taking some brain out and closing it without bone, how can you avoid this? So my story starts in 2006 in India, in a small medical college in India, where to cut a long story short, I mistook a trauma for an aneurysm because my assistant switched cases, rightfully because the trauma had dilated the pupils, and I went in. Don't ask me now because it's a long story. I can tell you somehow. Maybe Ahmed will be able to explain it to you because he's been with me. But I exposed the trauma and I worked at it just like I would do an aneurysm. So I went into the subfrontal subfrontal cisterns, opened up all the cisterns, tried to look for the aneurysm, and I didn't find the aneurysm. But the side effect was that the brain was lax. That is when I started thinking whether we can start doing this. And so we started doing it in 2007, 13 years back. So some of our first cases, GCS 4/15, left pupil dilated, decompression of the temporal bone. So here we'd already started putting our bone flaps back. But we used to do a large temporal decompression, and therefore only a rim of the bone used to be kept back. You can see how bad this case is. I mean, there's no cisterns, there's severe edema, there's blackish discoloration everywhere. You see, it's pretty bad. And this is what happened after surgery. You can see the thin rim of bone. You can see it in this cut, thin rim of bone sitting there. The difference is that the cisterns are opened up. The cisterns are open. That is the difference. You can see all the cisterns, they're open. And see this guy. 7th postoperative day is saying his name. So that's what led us to believe that this is something different. So then we've had a lot of cases, in fact, over 2,000 cases. And now we have over 30 countries doing cystonostomies. The first European series has been published, South American series has been published, Middle East cases have been published both from Iraq and Iran. There are many fellows from Middle East, North Africa, all parts of the world who's come and who's been with us. Now, for the last 14 years, I was in Nepal. And after this, I have moved on to one of the best centers in India. And this is the Krishna Institute of Medical Sciences in Karad, where we are installing a 170-bed neurosurgical center, probably one of the largest in the subcontinent, probably one of the largest in the world, with all facilities, including an intraoperative CT, all the necessary things, robotic scopes, and of course a cadaver lab, a state-of-the-art cadaver lab for all the fellows to come learn and exchange their ideas. Over the last 8 years, we've had so many fellows from all over the world. While we have taught them what we know about skull base, trauma, and vascular, we've also learned a lot from them. So it's always been an exchange, and this is exactly what we plan to do in Karad. This is our vision, to be one of the best centers in the world. Exchange information, teach, learn, and continue to be at the horizon, pushing the horizons of neurosurgery forward. So this is what we saw. Another case, you can see how much the CP angle cistern is widened. You can see the mass effect here. And that's post-op. The bone is kept back. There's a small extradural. Who cares? You can see another case with a massive midline shift here. There's a subdural, but the midline shift is far, far worse. You can see the posterior temporal lobe. The parahippocampal gyrus is already herniated. You can see in this cut, the parahippocampal gyrus is already herniated. Okay. Now you see the guy. Okay. This, in decompressive craniectomy parlance, is nothing short of a miracle, because we've seen enough decompressives also, and we know what the results are. It's a primitive surgery. I believe its time has come. The time has come for it to end. And just like microneurosurgery started in the rest of all neurosurgical branches, microneurosurgery should start for trauma as well. And why it's important is because people from the third world, our part of the world, has the maximum number of trauma. And also, we do decompressives. We put a plate which is manufactured by a European or an American company, and therefore we don't learn any skull base, and we go and we watch skull base, which is done in some Western universities. All our fellows, all our residents are doing that. Instead of that, if we knew how skull base is done, like the previous speaker has shown, if his expertise was put to use, I mean, cystonostomy would not be anything for him. So if those kind of people take the initiative and start skull base and vascular principles in trauma, none of you will have to go any place to learn skull base or vascular. Now I'm going to show you a few more cases where decompressive would have resulted in disaster. But you see cystonostomy, see this kind of cases where, the brain is so tense. See this one. You talk about Duret's hemorrhages, they are here. See this cut, and you can see the Duret's hemorrhages in the brainstem. Okay. You see the retraction injury, the retraction that we had to do, and that's a retraction injury, and to get into the cisterns. People ask me, how can you retract? It's better to retract the frontal lobe and injure some part of the frontal lobe to get into the cisterns than kill the patient. See her, the 7th postoperative day. See her, the sutures are not even removed. She's in the ICU, okay? But with that scan, I don't think any place in decompressive hemicraniectomy would have saved her. See this scan. See the post-op. Another one. See the burst slope. See the subdural. See how much bad is this picture. No decompressive. No decompressive. See the patient in my office. Okay. Came walking to my office before discharge. See this acute subdural. See the post-op. See this. See the post-op. We also had studies with the ICG to see the blood flow to these places after cystonostomy. It's an interesting paper, will come out soon. See this case. Burst lobe, acute subdural. Before opening the dura, after opening the dura, how the brain is bulging out, and after cystonostomy, you see that. This is from Czech Republic. His skin-to-skin time is now 65 minutes. ICP, how he shows it's dropped from 48 to 11. Another case, acute subdural, post-op, acute subdural. See the space that you have after cystonostomy. Another one. See the brain. And this is my boy, the boy whom I have trained in cystonostomy. So this is how they've been. This is the membrane of Lilliquist being opened, and they are operating. And I'm sure Ahmed will tell you where when I was in Nepal, these boys, my junior boys, were starting to do it. So the same way in India, I expect that we start our residents start this, and this is how it's closure. This is how it is at closure. Brain is so lax, Bone flap is kept back. Now, what's the principle of this? The principle is CSF shift edema. It's very simple. You must understand that our work on CSF, the CSF is there for a purpose. It's not as a floating agent for the brain. The CSF cools and cleans the brain. So all our sinuses, they're acting like an air cooler. So when we are taking breath, when we are taking breath, what happens is this wet sinuses, the wet mucosa in the sinuses, they evaporate. And because the latent heat of evaporation is lost, the sinuses become cooler. It's like wearing a sweatshirt, wearing a sweaty shirt and sitting under the fan. So when you do that, you are cooling, you're humidifying the room, but that is not what you intend to. You don't sit under a fan to humidify the room, do you? You sit under the fan to cool yourself. So that is what the sinuses are doing. It cools, the sinuses are getting cooled. And where is the suprasellar cistern? The suprasellar cistern is right in the middle of all these sinuses. So the suprasellar cistern is also cooled by 2.5 to 3 degrees. And this cooled CSF, suprasellar cistern, you must understand all the vessels come from the suprasellar cistern and go into the brain. So there are these small spaces around these vessels. So the CSF is pumped into these small spaces around the vessels because of the pulsation of this vessel. And it is called Archimedes screw principle. We described it for the first time. So there is cooling of the brain. And in the night when you sleep, the aquaporin 4 channels open. And this CSF from the Virchow-Robin spaces also goes into the ISF. And they drain off all the lactate and the chloride and all the other things as well. So this is the cleaning pattern. So this is how CSF works. CSF goes into the brain rapidly from the suprasellar cisterns. You must understand it does not go from the ventricles into the brain, but from the suprasellar cisterns and other cisterns. The CSF rapidly goes into the brain. Exactly what is happening in trauma. So when there is trauma, there is subarachnoid hemorrhage. And with the subarachnoid hemorrhage, what happens is the pressure inside the cisterns goes up because blood is a newcomer and blood is coming at rather high pressure. So what happens? There will be blood in the cisterns and all the CSF will get displaced through the Virchow-Robin spaces into the brain through the Virchow-Robin spaces. And therefore, the brain swells up. Imagine you take a 100 or a 1 liter Coke bottle and try to inject about 80 ml of normal saline into that Coke bottle. See the pressures, how it will go up. Exactly what happens. So doing a decompressive will not help you because if you do a decompressive, 12 into 13 centimeter large defect, and the brain is coming out about 1 to 1.5 centimeter. That much brain, whatever went into the brain from the suprasellar cistern, that much brain is herniating actually into the decompressive site. That will be okay to save your life, but that brain is gone. Many studies are there which shows that decompressive hemicraniectomy, it's better that it is not done. If you are a bit unkind, you can say that you are converting a cemetery into a vegetable market. So that is not exactly what we want. In a third world country, these patients are a burden to the family and to the government. We cannot really allow this primitive surgery to go on. We have to start, like in aneurysm surgery and skull-based surgery, we started using microsurgical principles. Trauma is the most common pathology, and we must start using microsurgical principles. Trauma is not something secondary. Now, these are our experiments. We had a weight drop model. If our assumptions were correct, we would have seen blood in the cisterns and CSF in the brain. And we saw that the restituted hyperintensities 15 minutes after the trauma. It could be blood, it could be water. So we saw there is blood in the cisterns, and there is displacement of neuronal structure, showing that there is water influx. So the CSF shift edema was proved with basic science in Calgary, in Canada. And people ask me, why can't you put an EVD? Because the EVD does not communicate. The ventricular CSF doesn't communicate with the brain. How you know? You inject a marker into the ventricle, and this is what happens. Inject a marker to the suprasellar cistern, to the cisterns. This is what happens. There's communication. So when two balloons are communicating, you put a hole in one balloon, the other balloon also, the pressure in the other balloon also comes down. Imagine brain and the CSF as two balloons which are communicating with each other. You open the cisternal compartment to the atmosphere, that balloon's pressure comes down, and then the brain pressure is also going to come down. It's very simple. This is Ilif
actually does so along very specific anatomical structures. There's a specialized anatomy that allows the CSF to move very quickly and very deep into the brain, exchanging with the fluid that's inside the brain and then moving out.
So this is the pathology that I told. That is what happens in decompressive hemicraniectomy. After this is CSF shift edema. In cystonostomy, this is what we do, and decompressive, this is what we do. So to get into the base of the brain, as Abdullah was talking about the skull-base surgery, we need to unlock the brain in axial and sagittal planes to get into the base of the brain. Otherwise, if you try to get in from the top of the brain, this is disaster because the brain is very swollen. Now, this is one video which will show you a transcavernous approach. This is a cutting of the orbitomeningeal band, and then a transcavernous approach. But believe me, this is all relatively new. In my last 13 years, this is probably about 6 or 7 years old. So this is not how we used to get into the base of the brain. If I show this, people are going to think, oh, maybe I'm not going to do this. So I'm going to show you, as usual, my earlier very, very bad surgical videos, so that you understand that, you can, without much of this ACP, PCP removal, you can get into the base of the brain, and then you can go ahead and drain. You can put some retraction on the frontal lobe. People are worried about retraction on the frontal lobe, but people are not worried about
Oh, I think we're having bandwidth problems with IPE too. So we just be patient and wait. And IPE is an experienced presenter. He'll be back. Just be patient.
Am I seen now?
Yes.
Right.
You want to share something, right?
Yes.
Yeah.
You're seeing?
Yes. Okay.
You're seeing it?
Yeah, you're on the way. Yeah, there you go. Getting to the
Okay,
base.
so now, yeah, now I'm going to show you some of the worst videos. See, this is a very, very severe brain swell. I'm not going to run through it. This is the only thing I want you to see. You have understood the CSF shift edema. You've seen the radiology. You'll be wondering how you do it. See the brain coming out. Okay? And see the opening. It's only 2.5 centimeters. See the brain coming out. Say ah. Okay? Say ah. All right? This is as bad as it can get. But you are into the optic nerve soon now. And once you're into the optic nerve, your brain swelling is going to come down. And see the opening. Its opening is only 2.5 or 3 centimeter. You are into the base. See the kind of force I need. That's when you appear. People tell me, oh, this is not good. This is a lot of force. We don't apply that kind of force these days because we use a lot of skull-base technique. But even without any skull-base technique, if you take out a little bit of frontal lobe, basifrontal lobe, using the microscope, it is far better than the hypocrisy of telling me, oh no, we don't use the microscope, but we just open the dura and allow the brain to swell. That is nonsense. Okay, so you use the microscope, do a little bit of this retraction. This is when you don't have a subdural. When you have a subdural, it's much more easier. Once you remove the subdural, much more easier. Okay, and you're getting into the optic nerve. Okay, you got the carotid and the optic nerve. You start getting CSF now, and the brain becomes much, much more manageable. I wanted to show you these videos because I want you to say, ah, is this what I'm going to do? Yes. This is how you start off. And then you get much better. Even my boys are much better now. Ahmed will tell you, it's always not this bad. Now you get into the membrane of Lilicus. You see, I took less than 5 minutes. You count the time. It's less than 5 minutes to get into the basilar. Less than 5 minutes. Okay? That's a basilar. That's a basilar artery. Right? And the brain is now lax. You put in a tube. Okay? Don't bipolar, just keep on irrigating. And once you put in a tube into the prepondine cistern in front of the basilar, you're done. We're not fast forwarding it. It's this fast. I mean, cystonostomy doesn't last. So now the brain swelling is, see the pulsation. See the pulsation. Then, if there is a large subdural, you can open. Okay? Now you can open. If you open, large subdural, difficult swelling, the brain will be on your face. So first do a 3 centimeter, 2.5, 3 centimeter, get into the base. Don't damage the vessels. And after that, you can open, and then you can do your second round. Okay? To see whether there's bleeding. Control the bleeding. And let me assure you, once your ICP goes down, the bleeding goes down. You've seen this, many of you would have seen in tumor surgery and aneurysm surgery. Once your ICP goes down, your bleeding goes down. Okay, all the venous bleeding will stop because the ICP raises the cerebral venous pressure. So once the ICP goes down, the venous bleeding goes down. And then it's much more simpler if you put in larger magnification and then you start washing out all the blood for maybe 20-25 minutes, have some patience, wash out all the blood, and then you open the dura, you will find that there is no need to take off this bone flap. Okay, you can see the CSF coming out. You can see how much damage that brain is, but no problem. You can see CSF keeping on coming out. That's the basilar artery there. Pituitary stalk also can be seen. Carotid, opticocarotid, that's a basilar artery, clearly seen. You can see even there is tachycardia for this patient. Put in your drain, come out. See the brain? It's not that it is difficult to close or something. There's so much damage for this brain, frontal and temporal lobe, but no problem. Brain is not coming out, or we have not gone and removed blocks of brain. Nothing. The brain is pulsatile and lax. See another one. I wanted to show you all these very, very bad cases. Okay. From the at least 5-6 years before. You see, you open and then see the brain coming out. Okay. Put in a stitch, pull the dura, open. So don't tell me we are not seeing brain edema. Some people tell me, oh, you don't see this kind of brain edema or brain fungus. You're opening again only 2 centimeter, 3 centimeter of this. That is all, nothing more. And see, after cystonostomy, this is it. Only that basifrontal 1 or 2 centimeters of brain is damaged. Who cares about it? When you have such things at stake, when you have the patient's imminent death or severe morbidity, this is a small price to pay. So get into microneurosurgery. Okay, this is my message. Now you can read about the indication score, about the ipsilateral CP angle system widening and its importance, all the pressures, all the studies from all over the world, anatomy, physiology, which I have told you, surgical review. All this you can keep on reading. It's all available on the net. Okay, Ahmed can help you. Now you know what is the criticism? The criticism is that most of the residents do not know how to do it. Therefore, we should continue to do decompressive. I challenge all of these guys. Can you tell me that most of the residents don't know how to do petroclivals? Most of the residents do not know how to do aneurysms. Most of the residents don't know how to do other tumors. So let us do decompressive for all of them. If that is acceptable, then I'll say probably this critique is also acceptable. It's I don't have to say that it is nonsense. It is. So Geno study. This is the cystonostomy being included. The online registry, everything is coming. As I have talked to you about the cooling and the cleaning system, the Archimedes screw principle, everything I have already told you. This is a Springer Neurosciences chapter. We were honored to have this as a chapter in 2013. 7 years back, we proposed the cooling and cleaning. If you type cooling and cleaning of the brain, this is our work. It is this is the Springer Neuro series. Thank you very much. I stopped sharing now, I guess.
Yes, please.
What happened, John? Are you okay? I heard a very strange sound.
Okay. Okay, I guess we're going to have a little discussion, correct? Is that correct, Ahmed?
Looks like you were drinking something, John.
No. Yogurt.
I see. 5 minutes for questions.
Yes.
Go ahead, questions, please.
No question.
Okay.
We will shift to next speaker. Thank you, Dr. Thank you.
Fantastic.
Thanks, Hype.
Okay. Thank you so much.
Thank you, guys. It was an honor.
Second year in a row for Yemen, Hype.
No, everybody.
The
Huh? Yes.
Munir Zain will give us a lecture about histological pattern of CNS tumors among Yemeni patients, a retrospective study of 10 years period. Okay.
خلاص اشرب هذا هنا وخلاص انا بنسى اشرب هذا تكلم عن مجموعه الان بنشوف
السلام عليكم. Okay. This study is histopathological pattern of CNS tumors among Yemeni patients, a retrospective study of 10 years interval. No. Okay. لا ما بيمشي ليش Central nervous system tumors are rare, constitute 1 ila 2% of human neoplasm, but it is one of the most important cause of the death. The primary brain tumor are a diverse group of neoplasm. More than 120 histological type of this tumor has been classified according to WHO. The CNS tumor are not classified according to the stage, while it is classified according to the grading. They are grading from 1 to 4. And this grading is dependent on the histopathological examination. The grading become bigger when there is necrosis or increased mitotic index or severe cytological atypia. And due significant increase of incidence and death rate from brain tumor, this tumor has a special importance because the prognosis of this tumor is relatively poor, because the average age may become low, the 5 survival rate, I mean here, and even the benign neoplasm in the brain can turn lethal due to its location or maybe due to predisposing for malignant transformation within short time. As we say, there is no any study done in Yemen. That's why my objective, it was as a result of CNS tumor deficit in the information in Yemen. So we try in this study to focus on frequency of CNS tumor in relation to demographic data, the available demographic data as age, sex, and tumor type with site. This retrospective study was done in the histopathology department in Saudi German hospital. It is retrospective analytic study for 10 years from 2009 to 2019. The basic data, as I said, age, sex, site, taken from the histopathology department in Saudi German hospital. And the CNS tumor was classified according to WHO 2007. The population of this study composed of 359 patients divided into small group, pediatric group from 1 to 18 age. It represents 17% with men age 9, while the adult group from 19 to 17, and it represents 82% with men age 44. In the adult group, the most predominant sex, it was a female, 55%, while the male only 44%. The same things in the pediatric, it is different from the most literature that mentioned the CNS tumor is more common in the male than female, but in our study we find it is more common in the female than male. The distribution of the CNS tumor, here it is distribution of the CNS tumor categories, not specific entity. We found the first tumor, it was gliomas or neuroepithelial tumor, consisting 28%, followed by meninges tumor 26%, then mesenchymal tumor 13%, while nerve sheath tumor and cellular tumor are equally distributed 11%, 14 patients for each entity.
Are you having trouble advancing?
No.
Okay.
It's not from me.
Okay.
As I say, the most common tumor, it was predominant in the female, 55%, while the male, it is only 44%. The most common tumor of the CNS that affected the male, it was gliomas, 15%, followed by cellular tumor, 6%. While the other tumors are more prominent in the female. The cranial nerve tumor and paraspinal, which I mean nerve sheath tumor, are equally distributed in both sexes. If we see the frequency of the CNS tumor here, the most common tumor as category, it was tumor of the meninges, 31%, with a special entity grade 1 and grade 2 meningioma, followed by tumor of the gliomas, which is the most common entity. It was pilocytic astrocytoma and GBM. Sorry, in the adult, it was GBM. The third tumor, it was nerve sheath tumor, 12%, with most prominent entity schwannoma. The cellular tumor here, it come in the fifth tumor as category, 11%, but in the single entity, the pituitary adenoma, it formed the second single entity tumor after grade 1 meningioma. Again. The frequency tumor in the pediatric, it was as a big category, 48%, it was glioma. The single entity increase in the male, it was pilocytic astrocytoma. The follow-up tumor is embryonal tumor, 20%. Single entity, it is medulloblastoma. Then the mesenchymal tumor, 18%, with single entity lymphoma. Here in the MOS study, we are going with the MOS study of CNS tumor frequency in the pediatric. They mentioned the most common is pilocytic astrocytoma followed medulloblastoma, but some study in the region like Saudi, they mention, or even in the south of Yemen, in Aden, Al-Aden Oncology Center, they mentioned the first pediatric tumor in the pediatric medulloblastoma followed by pilocytic astrocytoma. Here, the third common tumor in the pediatric is lymphoma. Maybe it is logic because Oncology Center register mentioned the lymphoma. It is one of the most common malignant tumor in the pediatric and in the adult group. The frequency of the tumor according to the site, most of the tumor, about 80%, 85% was intracranial, only 14% it was intraspinal. The intraspinal in the adult group, the intraspinal, it is slightly raised 18% because the most common metastases are more commonly presented in the adult that may raise the amount of the intraspinal tumor. But in general, it is more common in the intraspinal than intracranial than intraspinal. Here, the grading, WHO grading, as we said, the CNS tumor are graded into grade 1 to grade 4. In the pediatric group, we found that grade 1 equal 46%, followed by grade 2, 28%. Then grade 2, 12%, grade 3, 5%. The grade 1, we considered grade 1 and grade 2 as non-malignant tumor or benign tumor, while grade 3 or grade 4, it is equal malignant tumor. Here in the pediatric group, the grade 4, it become higher, 28, because the most cases of the tumor, it was medulloblastoma. In the adult, also more than half, 50% of the cases are grade 1. That because the meningioma, it was the most common tumor in the adult with grade 1 and grade 2, followed by grade 2, I mean here grade 2 meningioma, and mesenchymal tumor. The mesenchymal tumor, most of them are benign, only the lymphoma and angiosarcoma. Angiosarcoma represented as 1 cases, while lymphoma represented as 10 cases. Conclusion, the CNS tumor are common in female with mean age 36. The categories was gliomas and meningioma in both adult and pediatric age. Non-malignant tumor or low grade were common than the malignant one. The pediatric site was intracranial more than intraspinal. The adult CNS tumor revealed female predominance, mean age 44. And the most common tumor were meningioma grade 1 and grade 2, followed by pituitary adenoma, glioblastoma multiforme, and schwannoma. The pediatric CNS tumor revealed slight female predominance, mean age 10. The most common tumor were pilocytic astrocytoma, followed by medulloblastoma, then lymphoma. We couldn't gain statistics significant in many of our value due to small size. However, this study is highlight for meticulous data collection and maintenance of registry of CNS tumor to study the epidemiology of the CNS disease in the Yemen population. Thank you.
Thank you, Dr. Munia. Any question for Dr. Munia? Any question? Dr. Latif.
Thank you, Dr. Munia, for this lecture. My question was, we are neurosurgeon. For you, Mr. President, what is important? We describe our result in the operation. In the paper, we send to you what is important for you and help you for good diagnosis. Must we write about the tumors?
You mean what's the importance of this paper or what?
No. When I send to you for histopathology, the paper for you. But important, we write about our tumor.
What's the important?
Our request for
Yes,
you.
in the CNS tumor, as I say,
Because the result of histopathology is important for prognosis, for treatment. For
of course. In the histopathology diagnosis, we must mention the type of the tumor, and the grade of the tumor, because as I said, the grade of the tumor is very important in the prognosis. For example, when I said meningioma, so after that, I should say benign meningioma, WHO grade 1 or grade 2. If I said atypical meningioma, I should mention atypical meningioma, WHO grade 3, grade 2, anaplastic meningioma, WHO grade 3. That's very important because the prognosis is the grading is related to the prognosis. And as I mentioned, there is no CNS staging, tumor staging. It is depend on the grading. That's point with you.
Dr. Moni, I have one question here. It's important to send with the histopathologic request the report of MRI or CT scan or no?
Yeah, it is very important to send, or at least to write for in the request. The surgeon, the most important we're facing as a histopathologist, inadequate clinical data in the request. For example, they said, all of you are most neurosurgeon, and you know, they said it is only brain mass. So you should mention brain mass, site of the tumor, where it is supratentorial, infratentorial, whatever it is. And also the result, you can write simply the result of the MRI or CT.
But sometimes we think we are cheating them about this.
You are cheating who?
For histopathology.
Yeah. No.
Doctor.
I cannot hear you, doctor.
Reading of tumors is very important, not only in prognosis, but also in treatment.
Yeah.
For example, in grade 1 and if patient underwent total resection, no need for further treatment, okay? The grading is very important in deciding what you should.
And I think we are lucky because the result of this study, even if we have a small population, but we are lucky. The most common tumor, grade 1 and grade 2, and that's considered malignant. As Yemeni population, okay, it is good. Grade 1 and grade 2, it is good because it is considered benign, a benign tumor, non-malignant.
Type of adjuvant.
Yes, and the treatment is depend on the grading. Yeah.
Grade.
Yes, yeah.
Grade 3 and grade 4, even if patient underwent complete surgical excision, we need to give an adjuvant chemo and sometimes chemo radiotherapy.
Yes, you are.
Thank you so much.
You are welcome.
عفوا دكتورة.
بسم الله الرحمن الرحيم. دكتور علي الأشول, clinical oncologist. Thank you, Dr. Moni, for this informative and very nice lecture and data. Some query, I think all of us see some different in the percentage of tumor. I'd like to clarify this thing because any community has special risk factor. This is the first thing. Second thing, this study has what we call it hospital-based study. In cancer, we have two types of study, hospital-based and national-based. In Yemen and Arab countries, unfortunately, there is no national-based cancer registry. That's why all studies hospital-based. That's different. It can come due to the flu and the type of people who attend the hospital. Regarding the second thing, for us as oncologists and also neurosurgeon in the malignant grade 2 and 3, we need debunking, not like grade 1 and 2. And for histopathology, sometimes to know other like other cancer, stay margin and other characters, it is very good for outcome. But in the brain, it is difficult. But for the benign, and grade 1 and also grade 2, total resection had to be clear for us as oncologists to decide if this patient need further treatment or not. Thank you, Dr. Monia, and thank you.
Yes, about this study is a retrospective study analytic. Really, yeah, I tried to go to the Oncology Center in Sana'a, but unfortunately there was not enough registration. That's why I developed my own registration in the Saudi Armani in the last 10 years. That's why. So I hope, inshallah, further study in this issue, CNS tumors. Okay, thank you.
Dr. Aminia, thank you. I think from the retrospective studies, I need to ask about if there is any cooperation with Adan registration cancer in this study.
Yes.
Is there any cooperation with Adan Cancer Registration Center?
Study?
Yes.
No, just I read one paper or two papers. One of them is Dr. Bawazir and in Adan Oncology Center, who mentioned.
No.
In general, all the mention, all the study done is only registration or to see the frequency of all tumor, but as a specific tumor, no.
No, not
no.
specific tumor, but they are registration of all the tumor, and they classified all for each system.
I don't know.
And there is one study of the nervous system tumor in Aden.
It is not through the paper. I done the paper from Adan Oncology.
I study is a massive attraction to give us a strong go forward to register.
Okay, once again, the transmission is frozen. Just be patient. We knew this may happen, but we're willing to go ahead and try. Well, Victor, how you been? Oh, okay. I think.
Fine, fine. Thank you. Thank you for the invitation. Now we are almost 4 or 5 brain surgeons from Mexico City.
Wow.
This is great because
okay, excuse me, Victor. Excuse me, Victor. I think they're starting again. Excuse me. Okay, Mohammed, are you going ahead?
Assalamu alaikum. I am Dr. Hafdullah Abdul Wahab, as a neurosurgeon in Central Military Hospital. I will take about Cushing disease. طبعا أنا بستخدم اللغة العربية بشكل أساسي لأنه لغتي الأساسية عربية، درسنا بالعربي لسوء الحظ أو لحسن الحظ.
I think if you go on the bottom, you can make it bigger.
Producing pituitary adenomas cooperative study of hormonal criteria of remission after surgical resection. We can see that there is nothing more challenging than diagnosis and treatment of ACTH secreting adenoma. ممكن احنا نجيب على هذا السؤال بالبدء بحالة مرضية وهي آخر حالة وأصغر حالة تدخل في الريسيرش تبعنا. في عندنا طفل 8 سنوات تظاهرت الأعراض لديه بالأوبيسيتي، تأخر في النمو، إضافة إلى appearance of secondary sign of puberty. بالفحص السريري وكلينيكال اكزامينيشن البيشنت شورت اوبيسيتي، اضافه الى تشققات ارجوانيه سكندري ساين اوف بوبرتي. هذا الصوره للطفل عمره 8 سنوات طبعا. اجري له دراسه مخبريه الاي سي تي اتش 139، الكورتيزول 19 الصباحي، طبعا كورتيزول المسائي كان 11. طبعا الكورتيزول الصباحي والمسائي عمليا ضمن الحدود الطبيعيه، المسائي لل 13 والكورتيزول الصباحي حتى ال 23. اجري المريض رنين مغناطيسي للدماغ with contrast and dynamic MRI كان نورمال طبيعي. اضطرينا اجراء لقسطره الجيب الصخري او انفيريور بتروسال ساينس كاتريزيشن، وكان دراسه المدروج المركزي الى المحيطي او سنترال بريفرال جرادينت. النتائج كانت على النحو التالي: في الدقيقة 0 أو الزمن القاعدي كان البريفرال 343، بينما في الرايت بتروسال الانفيريور بتروسال ساينس كان 295، بينما في الليفت كان 1100 أو 1081. لاحظنا أنه في الدقيقة الخامسة كمان بعد إعطاء السي ار اتش للتحريض ارتفعت مستويات الكورتيزول، خصوصا في الجهة اليسرى من أو نسميه ليفت انفيريور بتروسال ساينس. هذا طبعا بيساعدنا في الدراسة في تحديد كون الرنين المغناطيسي طبيعي، بيساعدنا في تحديد الورم فيما إذا كان في الجهة اليمين أو اليسار من الغدة النخامية، مما يساعدنا في التداخل الجراحي، لأنه إحنا بنعمل هنا اكسبلوريشن للبيتيوتري جلاند بفتح البيتيوتري جلاند والبحث عن ورم في حال كان هنا لدينا الرنين المغناطيسي طبيعي. طبعا يجري المريض تداخل جراحي ترانس نازل ترانسفونيدال ابروش. اثناء العمل الجراحي تم اجراء اكسلوريشن للبيتيوتري جلاند، لاحظنا وجود ورم هش بحجم حوالي 2 إلى 3 ملي. تم استئصال الورم بارسال هيستوباثولوجي، كان النتيجه الاي سي تي اتش برودوسينج بيتيوتري ادينوما. اجري للمريض دراسه مخبريه بعد الجراحه، الاي سي تي اتش كان في الاسبوع الاول طبعا 1، بينما الكورتيزول 2.3. هذا افتر 6 مونث فروم سيرجري، هذا المقارنه. طبعا الصعوبه هنا تاتي في انه احنا الرنين المغناطيسي كان طبيعي، والتحاليل المخبريه في البدايه كانت تقترب من الحدود الطبيعيه، بالتالي كان التشخيص صعب، لكن اعتمدنا هنا على اجراء انفيزيف، يعني بروسيجر انفيزيف اللي هو عباره عن انفيريور بتروسال ساينس كاتريزيشن. طبعا كوشنج الدراسه يعني كوشنج ديزيز طبعا عباره عن سيريس اندوكراين ديس اوردر ناتج عن اكسس سكريشن اوف اي سي تي اتش يعزو الى البيتيوتري ادينوما. الكوشنج ديزيز طبعا يترافق مع هاي موربيديتي اند هاي مورتاليتي، تصل الى حوالي 50% خلال 15 سنه في الحالات غير المعالجه. بالنسبه للخيارات المعالجه سيرجيكال ريسكشن او دراج ثيرابي اضافه الى الراديو ثيرابي او بايلاترال ادرينالكتومي. المعالجه الخيار المثالي هو عباره عن اجراء استئصال انتقائي لورم الغده النخاميه. طبعا من الخيارات المتاحه الاخرى استئصال شقي للغده النخاميه، استئصال نصفي، او استئصال كامل للغده النخاميه في الحالات التي يكون فيها ريكرنت. هدف الدراسه هي عباره عن دراسه المقارنه بين المورنينج سيروم كورتيزول ليفل خلال الاسبوع الاول بعد الجراحه، مقارنه مع اسم اللونج تيرم ريميشن او ريكرنس. اضافه الى ذلك الدراسه الشعاعيه والاي سي تي اتش، مستوى الاي سي تي اتش قبل الجراحه والهيستوباثولوجي بعد الجراحه مع الريميشن او الريكرنس. مكان الدراسه طبعا مستشفى الاسد الجامعي جامعه دمشق، هذا مستشفى الاسد الجامعي. مدة الدراسة استمرت من 6 شهور إلى 138 شهر، أي حوالي تقريبا 11 سنة ما بين الفترة 2000 إلى 2011. خضع للدراسة 83 مريض اللي يجري لهم على تداخل جراحي لاستئصال ورم الغدة النخامي مفرز للإي سي تي اتش، كان اللي استطعنا متابعتهم 68 مريض، كون 15 مريض في 10 منهم لم نستطع التواصل معهم، بينما 5 حدثت لديهم وفاة مبكرة بعد الجراحة. لاحظنا أن نسبة الأورام المفرزة للإي سي تي اتش تشكل حوالي 17% من مجموع أورام الغدة النخامية، حيث أجريت الجراحة ل 498 مريض، كان منهم 83 لديهم كوشنج ديزيز. وهذا المخطط. الدراسة حسب العمر كانت تتراوح الأعمار بين 8 إلى 62 سنة، وسطيا حوالي 36 سنة، ووزعناهم إلى مجموعات. المجموعة العمرية الأولى كان الأعمار أقل من 20 سنة، كانوا حوالي 10%، بينما بين ال 20 إلى 40 سنة 71%، بينما فوق ال 40 سنة كانوا 19%. بالنسبة للتوزع حسب الجنس لاحظنا ميول واضح للإصابة لدى النساء بنسبة 3.3 إلى 1. طبعا الجراحة أجريت للكل ترانسفونيدال سبلابيال. الدراسة المخبرية أول شيء استخدمنا دراسة مستوى الفري كورتيزول إن يورين أوف 24 hours، إضافة إلى ارتفاع مستوى المورنينج أند إيفنينج كورتيزول ليفل، وذلك لدراسة كوشنج سيندروم أو متلازمة كوشنج، إضافة إلى اختبار التثبيط بالجرعات المنخفضة من الدكساميثازون. هنا شخصنا متلازمة كوشنج، ثم بعد ذلك تم إجراء الإي سي تي اتش، وذلك التحديد في اعتماد المتلازمة على الإي سي تي اتش من عدمه. في الحالة التي تعمد على الإي سي تي اتش تم تحديد دراسة إجراء اختبار التثبيط بالجرعات العالية من الدكساميثازون للتحديد فيما إذا كان اكتوبك سكريشن أو كان بيتيوتري سورس. في الحالة اللي بيحدث فيها انهبيشن بيكون المصدر هو عبارة عن بيتيوتري سورس. الحالة التي ما بيحصل فيها الانهبيشن يكون اكتوبك اي سي تي اتش، وخاصة من الأورام الرئة. بالنسبة للتوزع حسب مستوى الكورتيزول الصباحي قسمنا المرضى إلى مجموعتين. المجموعة الأولى كان مستوى الكورتيزول بعد العمل الجراحي في الأسبوع الأول من الجراحة أقل أو يساوي 5 ميكروغرام للديسيلتر. وهذه المجموعة عمليا هي اللي بنعرفها بأنها لديها اسمه انيشال ريميشن أو هجوع بدئي. كان عدد المرضى 46 مريض من أصل 68 مريض، أي بنسبة 68%. المجموعة الثانية كان مستوى الكورتيزول الصباحي أكثر من 5 ميكروغرام للديسيلتر، وهذه المجموعة عرفناها بأنها هي المجموعة التي بقي استمر لديها المرض أو التي لم يحدث لديها ريميشن. كان عدد المرضى 22 مريض من 68 بنسبة 32%. هذا المخطط التوضيحي. بالنسبة للمناقشة، احنا المجموعة الأولى اللي كان مستوى الكورتيزول أقل أو يساوي 5 ميكروغرام بالديسيلتر، كان ذكرنا أنه 46 مريض حدث لديهم لونج تيرم ريميشن لدى 44 مريض، بينما حدث الريكرنس فقط لدى مريضين، وكان نقص هرموني بينما كان الشعاعي سليم، يعني الرنين كان طبيعي. في المجموعة الثانية اللي كان مستوى الكورتيزول أكثر من 5 ميكروغرام للديسيلتر، كان عدد المرضى 22 مريض، حدث اللونج تيرم ريميشن لدى حوالي 7 فقط، بينما استمر المرض أو الريكرنس لدى 15 حالة. طبعا النقص هنا كان هرموني في كل الحالات، وشعاعي لدى 3 حالات من أصل 15 حالة. هنا جدول لدينا يوضح أنه في المجموعة الأولى كان لدينا 44 مريض الذي حدث لديهم ريميشن، عفوا كانت نسبة الريميشن 96%، بينما في المجموعة الثانية حدث الريميشن لدى 7 مرضى فقط، أي أنه كان لديهم ريميشن لدى 32% أو هجوع، وكانت نسبة الهجوع العام 75%. يعني الفرق واضح جدا بين المجموعة الأولى والمجموعة الثانية، وبالتالي احنا بنعتبر الكورتيزول تحت المستوى 5 محدد للريميشن للهجوع بعد العمل الجراحي. هذا مخطط طبعا، وهذا وصف. بالتالي احنا بنسأل سؤال: هل الفرق بين المجموعتين هام إحصائيا؟ وبالتالي هل هناك علاقة وثيقة بين مستوى الكورتيزول الصباحي في الأسبوع الأول والريميشن أو الريكرنس؟ الإجابة طبعا استخدمنا دراسة إحصائية واستخدمنا فيها الكي مربع. لاحظنا أن الفرق بين المجموعتين كان هام إحصائيا إلى أبعد حد، وبالتالي فإن مستوى الكورتيزول بعد العمل الجراحي في الأسبوع الأول هو محدد بشكل واضح للهجوع. في حال كان أقل من 5 يعني عمليا المريض دخل في مرحلة ريميشن، أما إذا كان أكثر من 5 فيكون المريض عمليا حدث لديه ريكرنس او معرض للبقاء ريكرنس. طبعا استخدمنا كمان ضمن الدراسه مستوى الاي سي تي اتش قبل الجراحه وعلاقته بالريميشن من الريكرنس، وقسمنا الى مجموعتين ايضا. المجموعه الاولى كان مستوى الاي سي تي اتش 65 نانو جرام للتر، كان عدد المرضى 33 48% ونص تقريبا. المجموعه الثانيه كان مستوى الاي سي تي اتش اكثر من 65 نانو جرام للدي سي لتر، كانوا تقريبا يشكلوا 51% ونص. هذا المخطط. المناقشه لاحظنا انه في المجموعه الاولى اللي كان مستوى الاي سي تي اتش اقل من 65 كان نسبه الريميشن لديهم 76%، بينما في المجموعه الثانيه مستوى الاي سي تي اتش كان اكثر من 65 كان ايضا مستوى الريميشن 74%. اذا لاحظنا النتائج متقاربه، وهذا الجدول اللي بيوضح لنا هذا الكلام مخطط. بالتالي احنا من الملاحظه هذا نستنتج بالدراسه الاحصائيه انه لا فرق احصائيا بين الاي سي تي اتش قبل الجراحه مهما كان المستوى، ليس له علاقه بالريميشن او الريكرنس ابدا. استخدمنا الدراسه الشعاعيه ايضا، لاحظنا انه الحدث قسمناه الى 4 مجموعات. المجموعه الاولى المجموعه الاولى كان 9 مرضى 13%، المجموعه الثانيه 77%، طبعا وهي المجموعه اللي ميكرو ادينوما المجموعه الكبيره. المجموعه الثالثه الميزو ادينوما كان 6%، بينما 4% الماكرو ادينوما. هذا المخطط. لاحظنا في اثناء الدراسه ان نسبه الريميشن كان اكثر ما يمكن في الميكرو ادينوما، وبالتالي الدراسه الشعاعيه مهمه جدا في اكتشاف الورم من عدمه، اضافه الى حجم الورم مهم جدا في الريميشن، حيث يحدث الريميشن اكبر ما يمكن في الحالات اللي تكون ميكرو ادينوما، بينما في الميزو والماكرو والنورمال بيكون اقل. تمام. استخدم دراسه الهيستولوجيكال استدي، كمان قسمنا الى مجموعات. المجموعه الاولى كان عدد البيتوتري ادينوما كان 58 مريض، بينما ندولار او ديفيوز هيبربليجيا كانوا 8 حالات فقط. الانفيزيس بيتوتري ادينوما حاله واحده، في حاله لم يتم اخذ عينه بصعوبتها. وهنا طبعا اثناء الدراسه لاحظنا ان البيتوتري ادينوما كان نسبه الريميشن فيهم 81%، بينما في بقيه الحالات كانت اقل، خصوصا في الانفيزيف بيتوتري حاله واحده لا يمكن التقييم عليها، وكذلك الحاله اللي لم يتم اخذ عينه فيها. الحاله اللي كانت في ندولار او ديفيوز هيبربليجيا كان نسبه اقل، وبالتالي في الديفيوز هيبربليجيا ننصح باستئصال النخامه بشكل تام او حتى استئصال شقي. اذا في البيتوتري ادينوما في الهيستوباثولوجي البيتوتري ادينوما هي الافضل انذارا. احنا بهذه الحاله نكون جاوبنا على 4 اسئله. السؤال الاول في العلاقه بين الكورتيزول الصباحي بعد الجراحه والريميشن، لاحظنا انه اقل من 5 بيكون حصل ريميشن نسبه عاليه، بينما اذا كان اكثر من 5 يكون الريميشن قليل والاغلب هو الريكرنت. اضافه الى الاي سي تي اتش لا فرق احصائيا بين قيمته قبل الجراحه. الاجابه عن السؤال الثالث اللي هي شعاعيا الميكرو ادينوما هي الافضل انذارا طبعا. بالنسبه للاجابه على السؤال الرابع في العلاقه بين الهيستوباثولوجي البيتوتري ادينوما هي الافضل انذارا. وبالتالي احنا بنوصي هنا باللونج تيرم فولو اب ضروري بعد الجراحه، اضافه الى اثناء الجراحه نحاول استئصال الورم بشكل كامل لتخفيف معدل النكس. اضافه الى ذلك في حال كان الكورتيزول اكثر من 5 ميكرو جرام ديسيلتر ننصح بالتفكير باعاده الجراحه في نفس فتره الادميشن. كما ان نلاحظ ان التشخيص المبكر والمعالجه المبكره تقلل من الموربيديتي والمورتاليتي لدى المرضى. المتابعه طبعا تشمل اكثر من اختصاص، لان الكوشنج ديزيز يصيب معظم الاعضاء من النيوروسيرجري الى الغدد واطباء القلب واطباء النفسيين. ضمن الدراسه يجب ان ندرس الدراسه الهرمونيه الاخرى. الحالة اللي بيكون فيها الرنين طبيعي يجرى قسطرة الجبهة الصخرية السفلي. المرضى الذين لديهم خطورة عالية تخديرية يفضل هنا أن نبدأ بمعالجة دوائية باستخدام الكيتوكونازول، إضافة إلى أن المراقبة بعد العمل الجراحي يجب أن تكون لصيقة. مراقبة الإلكترولايت.
التايم
خلصنا. انتهت.
شكرا.
الله يكرمك.
Thank you for Dr. Hafidullah for this nice presentation. If there is any comment or any question for Dr. Hafidullah, any comment?
دكتور محمد خيشني. Thank you very much for this very nice and very highly selective subject, Dr. Hafidullah. My question for you, first question. Suppose you enter to the pituitary to remove this. You said you find يعني أنت حصلت كتلة هشة صغيرة. طيب لو فرضنا ما حصلت، هل you will proceed for hemi يعني removal of the gland or for total removal of the gland؟ هذا السؤال الأول. السؤال الثاني إنه البتروزال ساينس كاتريزيشن هناك من اللي بيعمل على أساس الانترفنشنال راديولوجيست ولا يعني نيوروسيرجن مع سب سبيشالست؟ ثانك يو.
شكرا. بالنسبه للسؤال الاول، احنا في الحاله اللي كان فيها الورم طبعا الام ار اي طبيعي، في بعض الحالات تقريبا 13% الرنين المغناطيسي ما بيلقط الورم، بيكون حجمه صغير. بالتالي احنا بنعمل اكسبلوريشن اثناء الجراحه. بتلاحظ انه في بعض الحالات بعضها يصعب الحصول عليها جزء هش من الورم واستئصال بشكل كامل عيانيا، وبالتالي كانت النتيجه واضحه. ما هو احنا ذكرنا انه من الخيارات المتاحه اللي هو استئصال الغده النخاميه بشكل كامل والبدء بمعالجه تعويضيه، احد الخيارات المعالجه، او الاستئصال الشقي للغده النخاميه، استئصال نصف الغده النخاميه.
ما هو الستاندرد قصدي، ما هو الفيرست لاين؟ هل تو ريموف نصها ولا كلها؟
ما فيش ستاندرد محدد، لكن في حال عدم وجود ورم والرنين المغناطيسي طبيعي فاننا ننصح باستئصال الشقي للغده النخاميه، استئصال نصفي او استئصال كامل. طالما ما فيش، طالما احنا عندنا الانفيريور اسمه بترنونال ساينس طالع بوزيتيف، يعني انه المصدر معروف انه من الغده النخاميه وغير واضح في الرنين المغناطيسي، واثناء التدخل الجراحي لم نجد اي ورم، الحل هو استئصال شقي للغده النخاميه او كامل. هذا المعيار. بالنسبه للسؤال الثاني، قسطرة الجيب الصخري.
ايوه، هل الراديولوجيست؟
نيورولوجيست.
دكتور أوسان، مستشفى الشرطة النموذجي. شكرا جزيلا دكتور على هذه المحاضرة القيمة، لكن الذي يوجهنا إلى التدخل الجراحي لاستئصال الجزء الشقي أو الكامل للبيتيوتري جلاند، ايش الذي يوجهنا متى اعمل جزئي او شقي ومتى اعمل كامل؟
لا، هو الخيارين متاحين طبعا، كل واحد حسب القرار اللي بيتخذه شخصيا. هو لانه الخطوره انه في الاستئصال الشقي انه ممكن تكون انت اذا ما فيش، احنا الان فرضا دخلنا في لاحظنا انه في ميلان للمدروج تبع الاي سي اتش الى اليسار، احنا بنفضل هنا انه يكون ايش؟ استئصال شقي للجزء الايسر من الغده النخاميه. في حال كان المدروج الطرفين اليمين واليسار متناظر، فاحنا بنفضل هنا الاستئصال الكامل.
دكتور جمال عنسي، مستشفى 48. في حالة ما يكون التيومر not visible by MRI، هل تعملوا work up for ectopic ACTH producing tumor ectopic other than pituitary؟
ما هو احنا ذكرنا انه بنستخدم اختبار التثبيط بالجرعات العاليه من الدكساميثازون. عاده في المصدر النخامي يحدث تثبيط انهبيشن، بينما في الاكتوبيك ما بيكونش انهبيشن وبيظل الاي سي تي اتش عالي وبيتجاوز حدود ال 200. بالتالي في هذا الحاله بنبدا ندرس الاكتوبيك باجراء اشعه مقطعيه للصدر ودراسه كامله. يعني نبدا بالدراسه المخبريه لتحديد اذا كان المصدر نخامي او كان المصدر اكتوبيك.
Thank you, Dr. Abdullah. Now we have Dr. cutaneous syndromes.
السلام عليكم ورحمة الله وبركاته. دكتور مطيع أبو عريج، استشاري الأمراض الجلدية والتناسلية، أستاذ مشارك بجامعة 21 سبتمبر، الأمين العام مساعد للمجلس اليمني للاقتصاد الطبية. اوكي. بس نبدأ بالمحاضرة، بس موجودة في المحاضرة تعريف. بس انتهي لي من هذا، اشتينا سلايدز اللي الصورة هذه شيلها. Still slightly. 7. Okay. اعمل لي عرض الشرائح. انا اقلب بعد ليش؟ لا ما استشتغل تروترو يعني. اوكي. بسم الله الرحمن الرحيم. Our presentation today about neurocutaneous syndromes. As we say, this is the dermatologist who often in examination inspect than more than palpate, and this is the dermatologist, and this is the neurologist who work deeper than skin. Yes, deeper than skin, deeper is neurocutaneous syndromes. The common features of this syndrome is congenital or hereditary and involvement of the organs, ectodermal organs that is give nervous system, skin, eyeball, and retina, and generally slowly fulfilling the hood. From this
Yeah, we're having problems with the microphone.
yeah, microphone, okay.
Can you try the audio again? Hello, hello, are you okay?
Yes.
Okay, we lost your audio there.
Many systems, skin and nervous system, and also eye. The relationship between this affected is the embryological development. That is embryology of neurocutaneous disorders that give the differentiation to give the melanocytes, Schwann cell, dorsal root ganglion, sympathetic ganglion, enteric ganglion, and chondrocytes. From this common features, we noted that patients with neurocutaneous syndrome need for multidisciplinary for follow-up and management of dermatologist, neurologist, and also ophthalmologist and radiologist. Really, we observe patients who come firstly to the dermatologist for complaining of skin lesion that may be hypopigmentation or hyperpigmentations or tumors that arises from the skin. But it is important for follow-up this patient and management with multidisciplinary of neurologist, in addition to dermatologist, neurologist, and ophthalmologist and radiologist. Disorders that classifies as neurocutaneous syndromes, including neurofibromatosis, fibrous sclerosis, Sturge-Weber syndrome, von Hippel-Lindau disease, Passes syndrome, ataxia, telangiectasia, linear Nefa syndrome, hypersensitivity, and incontinentia pigmentis. We started by the most common incidence is the neurofibromatosis. This is with autosomal dominant, have two types, neurofibromatosis type 1 and neurofibromatosis type 2. We started by neurofibromatosis type 1, which is most prevalent of neurocutaneous syndromes. Incidence is about 1 per 3,000, and it's autosomal dominance. Diagnostic criteria for this syndrome is we need for 2 out of the following 5 signs, which is 6 or more cafe-iolate macules, axillary or inguinal freckling, 2 or more large nodules, 2 or more neurofibromas or plexiform neurofibroma, in addition to the distinct osseous lesions and optic glioma and first degree with relative with neurofibromatosis type 1. This is cafe-iolate macule. As you say, there is slightly hyperpigmented patch or macules that present at birth. It is present in about 100% in patients with neurofibromatosis type 1, and it is characterized as facial sparing. طب النيورو الماكيو كافي ايوليت ماكيولز can be presented in other diseases or other disorders like neurofibromatosis type 2, McCune-Albright syndrome, ataxia telangiectasia, Bloom syndrome, Weston syndromes, and familial café aeolate macule. Axillary oronguinal freckles. This is hyperpigmentation freckle that commonly presented within the axilla. It is about frequently greater than 80% by 6 years of age. 2 or more areas like nodules. This is pigmented hematoma nerves. This type of benign tumors affecting areas specified by slit lamp examination, and it's present in about more than 74% in patients with neurofibromatosis type 1. 2 or more neurofibromas or plexiform neurofibroma. This neurofibroma began is a benign tumors that rising from peripheral nerves. It is a small rubbery lesion with slightly purplish discolorations. Plexiform neurofibroma are usually evident at birth and become enlargement to be huge and can cause deformity of the bone. Other finding: hydrocephalus, microcephaly, cerebral vessel aneurysm, puberty, and risk of hypertension. Also, higher incidence of phychromatocytoma in patients with neurofibromatosis type 1, unusual association involving myeloid leukemia, juvenile xanthogranuloma, and malignant peripheral nerve sheath tumors. That is malignant neoplasm that arises in patients with neurofibromatosis type 1, neurofibrosarcoma, and malignant schwannoma. Tumors of the central nervous account for significant morbidity and mortality in patients with neurofibromatosis type 1, optic glioma, meningioma that affecting the brain and spinal cord, neurofibroma, astrocytoma, and neuroleoma. Neurofibromatosis type 2 is a rare condition. It's located in chromosome 22. The gene is known as Merlin or Schwann. The diagnostic criteria for type 2 neurofibromatosis: one of the following 4 features is present. Bilateral, one of the following 4 features: bilateral vestibular schwannoma, a family history with neurofibromatosis 2, and either unilateral vestibular schwannoma, and any of the 2 following: meningioma, schwannoma, glioma, neurofibroma, or posterior subcapsular retinicular obesity, and multiple meningiomas 2 or more, and unilateral vestibular schwannoma. Symptoms of this neurofibromatosis type 2: tinnitus, hearing loss, facial weakness, headache, café aeolate spot also can be present, and skin neurofibroma. This is lesion associated with the neurofibromatosis, and the most one is the bilateral vestibular schwannoma in about 90 to 95% with neurofibromatosis type 2. Bilateral acoustic neuromas. This is hearing associated with hearing loss and students, headache, facial weakness, more commonly in the second and third decade. Subcapsular also obesity can be presented in about 50% of cases of neurofibromatosis type 2. Management in case of neurofibromatosis: laboratory testing, imaging study, MRI with gadolinium, imaging study of choice in both neurofibromatosis 1 and neurofibromatosis 2. MRI increase detection of optic glioma, of the tumor of the spine, acoustic neuroma, and also spots that occur within the central nervous system. So in management also we need for close multidisciplinary. For follow-up is necessary, regular clinical assessment and history, and like examinations also, yearly ophthalmologic examination, neurological assessment must be, and blood pressure monitoring and scoliosis evaluation. Neuropsychological and educational testing should be considered as needed also. All symptoms cases with the visual disturbance must be studied without delay, and cosmetic also intervention some night we need for cosmetic surgical. Genetic counseling also can be molecular testing for neurofibromatosis type 1 gene. Scenario with genetic testing is helpful in patients who are only have one criteria of the clinical diagnosis, or those with unusually severe disease, and those seeking prenatal and pre-implantation diagnosis. How to treat patient: primarily supportive, anti-epileptic drugs for seizure, surgery for accessible tumors, and orthopedic procedure for bony deformities that are associated with neurofibromatosis. Routines, MRI studies who screen for optic glioma is non-symptomatic children. Okay, this is nice pictures with similar to the plexiform neurofibroma. It looks like, but this nice pictures is in our country, which reflect the grade of the Yemeni pupil. It looks like plexiform neurofibroma. The second neurocutaneous syndromes are tuberous sclerosis. This is also can disease that affects many organ systems or other skin, including heart, kidney, bile. So it's a multi-systemic disease. It is isomal dominant trait, also with a tumor supersurgene that molecular genetic studies identified into foci. These genes are tumor supersurgene. Diagnostic criteria. Genetic diagnostic criteria.
Time. Quickly, Dr. Muti. Quick.
Yes. Genetic diagnostic, genetically and also clinical diagnostic criteria, different diagnosis. We need two major features or one major features with more equally or more than two minor features. Possible diagnosis either one major features or more than two minor features. Major features is hypomonantic macules, angiofibroma, angual fibroma, Chagrin patch, multiple retinal hematoma, cortical dysplasia, and subendymal nodules, and so. Minor features with including confetti skin lesion, dental enamel beads, intraoral fibroma, retinal achromic patch, multiple renal cyst, and non-renal hematomas. This is hypomonantic macule, which called H-leaf spots, observed in about 90% of the patients. Typically, it appears at birth or infancy. Another major features of the tuberous sclerosis is facial angiofibroma. It's about 75% of tumor sclerosis in tuberous sclerosis. It's arises between 2 and 5 years. Angual fibromas, about 20% overall. In adult Chagrin patch, that's large bulk on the lower back that have a bumpy to orange bill surface. It's seen in about 50% of individuals with tuberous sclerosis. Confetti skin lesions, and this is a dental enamel base also. Dental enamel base can be presented as the minor features in patients with tuberous sclerosis. Intraoral fibroma also occur in about 20 to 50% of individuals. Sorry. Ophthalmologic features also, there is a multiple retinal hematoma, with this occur in about 30 to 50%. Don't cause problems with vision. Also, there is a retinal chromic patch with area of hyperpigmentation of the retina, and it's occur in about 39% of tuberous sclerosis patients. Neurological features in patients with tuberous sclerosis, intellectual disability, behavior abnormality, seizure, various type occur in about 80 to 90%. Neuropathological features including subendymal nodules, cortical and subcortical hematoma, with colored tumors, and area of focal cortical hypoplasia and hydrotrophic. Yes. Okay. This cortical tumors. Okay. This cortical tumors and the subendymal nodules. And this is white matter lesions also, and this is subendymal gyanseostrosarcoma.
I think we lost the audio. I believe we can go ahead in the program, okay? Because I believe we have lost connection. Would you like to go ahead with the program? Your audio is not on. Okay, you need to turn your audio on. We can't hear you. We need your audio on. There we go. We need your audio.
والتايم باقي وقت ممكن
Okay, it's on.
اوكي تمام اوكي يمكن الكونكلوجنز from this we hope and request from this conference to establish a neurocutaneous clinic to be one of the recommendations of this conference. This neurocutaneous clinic, which including dermatologist, ophthalmologist, neurologist, and also cosmetic surgery. Okay, thank you.
Thank you, Dr. Muteh.
Any questions? Any questions?
Pronto.
معنا.
Now. اسمعنا.
Pronto.
Professor. Paulo. Mi senti? Sì.
We're having audio problems.
Now we have
Professor Paolo Ferrini from Pisa University.
Excuse me, you have too many microphones open. You have too many microphones open. Just one, please. You have too many microphones open. Somebody on the system has a microphone open.
Hello. Now, what about the connection?
Your connection's fine, but there's another one on that should be turned off. That's it. Okay, it's okay, I think, now. Okay, now you're off. We'll get it. Okay, you need to turn your microphone on. Okay. Can you hear me, Dr. Peroni?
Yes.
Okay, why don't I introduce you, Dr. Paulo Peroni. You're from Portugal, correct?
From Italy.
From Italy. I'm sorry. Okay, Paulo, why don't you take over? It's all yours.
Okay, thank you. Can you hear me? It's okay?
Yes, we can hear you perfect.
Okay. So I would like to thank the organizer for this kind of invitation, and a special thank is to Dr. Shamsaldin that came in Italy some years ago to do his residency with us in Florence. And you can see here some picture at the time. And we went also together to some congresses. These pictures are taken from a congress we had in Lisbon. That was European Congress on Neurosurgery. And in 2004, I went also in Yemen, in Sana'a. I had a very good time. I met the physician of the hospital, the neurosurgical unit of Sana'a. With my previous chairman, we did a very nice journey over there. And we did also some operations. So thank you to Dr. Shamsaldin. So now I'm working in Italy, in Pisa, where we have a new building dedicated to the neurosurgery, and we do almost everything. And in addition, we have also a lab in our hospital where we do some dissection of subcortical structure of the brain. So in this presentation, I would like to discuss how can we improve our microsurgical approaches thinking anatomically. That means using as anatomical landmarks gyri and sulci. In addition, I would like to discuss with some example as the knowledge of white matter anatomy is effective in the understanding of the spread of gliomas. That means learn the anatomy through the pathology. Okay, To do anatomically based neurosurgical approach, we need to understand three concepts. There is gyral anatomy, sulci anatomy, and the 3D architecture of the brain. This is a specimen that is seen from above, and we can appreciate that all the gyri presents continuity. So what means that superior frontal gyrus is continuous with the precentral gyrus, that is continuous with the postcentral gyrus at the level of the paracentral lobule. This continuity can be observed in all specimens, and this aspect is represent the invariance of the brain. So we can find in all the brains some constant structure that can be always present. This concept is very important because we can find all this repetition of gyri in all the brains we dissect. The same happen also for the lateral surface, in particular for the opercular portion of the hemisphere that present high degree of invariance. In particular, the portion of the opercular presents 4 consecutive U's that are always present and are very important anatomical landmarks. The first U is the triangularis part of inferior frontal gyrus. The second U is the opercular portion of the inferior frontal gyrus that is always intersected by the precentral sulcus. The third U is the subcentral gyrus that is always intersected by the central sulcus. The fourth U is the connection between the postcentral gyrus and the supramarginal gyrus. The supramarginal gyrus is the continuation of the superior temporal gyrus that wraps around the end of the sylvian fissure. We can find in all specimens this invariance. Also in the mesial surface, we can appreciate some invariance. For example, the single H gyrus presents always the single H sulcus that is going that gives off a branch that is the ascending branch of single H sulcus that indicates always the posterior aspect of the sensory motor area. That is the posterior area. So, stop. Okay, so this concept can be seen not only in the specimen, but also in the MRI. We can find all these things that we said in a preoperative MRI. Why are important these concepts? Because we can always identify the superior frontal sulcus that intersect always the precentral sulcus, and we can identify behind the precentral sulcus the precentral gyrus, and behind the precentral gyrus we find the postcentral sulcus, and behind we can find the postcentral gyrus. So we can identify all these landmarks in the brain and in the MRI. That is important because knowing these landmarks, we can identify the precise location of a lesion, intrinsic lesion in the brain. In particular, in this MRI, we see that this lesion is just posterior to the precentral sulcus. This is a precentral because it is intersected by the superior frontal sulcus. So this lesion is in the precentral gyrus, so in the sensory motor area, in the motor area, just close to the paracentral lobule. So we know before the operation that this patient is going to have some potential to have some motor complication after the operation. In this other MRI, the lesion is more anterior. Where is this lesion? If you look here, this is the superior frontal sulcus, precentral sulcus. This lesion is displacing the precentral gyrus posteriorly. So that means that this lesion is located in the superior frontal gyrus. Where is this lesion in the superior frontal? Is in the area where there is the supplementary motor area that presents a posterior and anterior part. So this lesion is here. It's useful, this concept, because we can apply this concept during surgery for this patient. How we can find this lesion? For example, also without neuronavigation, we can use, of course, navigation, but we know that the bregma is the 13 centimeter behind the glabella, 5 centimeters behind the coronal suture, that is the superior Rolandic point, that is the point where is the end of the central sulcus. This lesion is displacing, as I said, the precentral gyrus posteriorly, so more or less is here. So we do the craniotomy centered on this area. We can find the central sulcus using the inversion of somatosensory evoked potential. And we do a small cortisectomy in front of the precentral sulcus. So it's here in the superior frontal sulcus, we go behind the vein and we resect the lesion without touching the motor area, as the patient is fine. So we remove the lesion using gyra and sulci as anatomical landmarks. This is another case. Where is this lesion? It's more difficult to be sure where is this lesion with this axial image. But if we check the sagittal image, we can be sure that this lesion is in the parietal lobe because it's just posterior to the ascending branch of cingulate sulcus. The ascending branch of cingulate sulcus is always posterior to the sensory motor area, to the paracentral lobule, that is this, and is in front of the superior parietal lobule. So this lesion is in the superior parietal lobule. It's a safe area that can be approached safely through a microsurgical approach. The patient was fine after the operation. This is another case. This is a deep lesion. This is a cavernous malformation with an associated venous developmental anomaly. The lesion is just on the roof of the lateral ventricle, and this lesion is laterally to the cingulate gyrus. How can we approach this lesion? We can do a transcortical, interhemispheric ipsilateral, interhemispheric contralateral, but if we know the anatomy of the sulci, we can appreciate that this lesion is just close to this sulcus, this deep sulcus. All the sulci are directed toward the ventricles. Only the sulci on the mesial surface of the interhemispheric fissure are not directed toward the ventricle because they are developing according to the development of the corpus callosum, so they are horizontally orientated. So this lesion is close to the superior frontal sulcus. So what I did is to do a small craniotomy centered on the posterior part of the superior frontal sulcus at the level of the superior frontal gyrus. I opened the arachnoid, I dissected the sulcus, and at the base of the sulcus I did a small cortisectomy that allowed the exposure of the cavernous malformation that was removed completely. And this is the postoperative MRI that demonstrates expansion of the sulcus, but the cortex was almost normal, like you can see in these axial images. So that is not enough to do an anatomically orientated approach. We need to know also the subcortical anatomy that was investigated deeply in the last century by Joseph Klinger, that wrote a very nice atlas that is the Atlas of Human Brain. And in this last slides, I will discuss some concepts about the insular region. To expose the insula, we need to retract the opercula frontoparietal and temporal opercula. In this specimen, I removed the opercula in order to disclose better the insular region, that is a structure with a pyramidal shape, with an anterior portion with three short insular gyri, an apex, and the posterior portion with long insular gyri. And there is a sulcus that is the central sulcus of the insula that is at the same level of the central sulcus of the brain. After removal of the cortex of the insula, we can appreciate the extreme capsule that is represented by fibers that are connecting, is associational fibers of the cortex of the insula. They are connecting all the gyri together. After removal of the extreme capsule, we expose the external capsule. With high magnification, we can appreciate the external capsule present an anterior portion and the posterior portion are completely different anatomically structured. The anterior portion of the external capsule is composed by the uncinate fascicle and hypophyse. The posterior portion is composed by a claustrocortical and corticocortical fibers that are fibers related to the claustrum, that is this gray structure that presents the posterior portion, dorsal claustrum, and an anterior portion that is composed of cells of gray matter sparse in the anterior portion of the external capsule. This dissection demonstrates the dissection of the bundles of the claustrocortical fibers. And at the end of this section, we have all the boundaries of the insular region. The posterior boundary is the arcuate fascicle, anterior boundary is the uncinate hypoph, and the medial boundaries are represented by the claustrum, claustrocortical fibers, and more deeply the external, the putamen and the globus pallidus. If we remove a portion of putamen, we expose the anterior commissure that is going toward the temporal lobe and is joined the sagittal stratum. The region that is very important for surgery of insular glioma is the region anterior to the anterior commissure. That is the anterior perforate region, or ventral striate region, called also ventral pallidostriate region. Why is it important? Because through this region run the lenticulostriate arteries. So we should know that when a lesion grows here, we cannot remove completely. These are some view from anterior. This is the amygdala. This is the lateral olfactory stria. With the further dissection, we can appreciate the ansa peduncularis of the amygdala. And this ansa includes three bundles. The most superficial one is the diagonal band of Broca that is directed toward the septal region. The other bundles are directed toward the thalamus and the hypothalamus. With the additional dissection, we can observe very well the amygdala and the anterior commissure and the ansa peduncularis. This is the orbit, the roof of the temporal horn with optic radiation, caudate tail, and stria terminalis. Why is important this concept? Because an anatomical concept that can be applied to the insular tumors. This classification is very important, was provided by Yazargil in his books, and represents the diffusion of the spread of insular glioma. Yazargil is important, this concept, because he was the first neurosurgeon to think anatomically. He understood the insular tumor can be pure insular, frontoinsular, temporoinsular, or frontotemporal insular tumor. Why? Because these aspects are related to the spread through these fibers. When insular glioma spread mainly through the anterior portion of this region, through the uncinate fascicle, he goes to the frontobasal and temporomesial region. And what's up this with tumor, temporomesial, frontobasal. But the problem is mainly when the insular tumor grows anteriorly to the anterior commissure, because they grows in the anterior perforate region, in the ventral striatum area. So when they grows here, if you look on the coronal image, the glioma is grow in the anterior perforate region. So it's just cranially to the lenticulostriate arteries, so cannot be removed this piece of tumor. So we should plan an operation. We can remove a lot of tumor, but we should leave the portion of the tumor that is inside in this area. Again, these tumors can grow to the ansa peduncularis, to the banda diagonale Broca, and can go to the septal area, and can go also to the anterior commissure contralaterally to the contralateral amygdala. So these concepts are very, very important in understanding the anatomy and the spread of gliomas. So in conclusion, what I want to say is that the knowledge of Sulci and the gyre is an effective tool in planning neurosurgically approach anatomically based. And fiber dissection allows the understanding of 3D architecture of the brain, understanding of the spread of gliomas, and in particular, teach us how can we learn the anatomy through the pathology. Thank you.
Okay, Dr. Perini, thank you very much. Ahmed, are you there?
Yes, yes.
Okay, any questions from the panelists or other presenters? Okay, if not, we'll move on to the next speaker.
Hello, John.
Please.
Hello.
Dr.
Hello,
Paolo.
Hi.
Professor.
Go ahead, Mohammed. Go ahead.
Yes. Professor.
Yes.
I can't help. Paolo.
Yes.
See.
Yes, I can hear you.
See. Could you repeat that photo that we see before, because we don't have that good connection.
So the last slide, you say?
Could you repeat it, please?
The last slide?
Yes, yes, right. Yes, that in Yemen when we were here.
Okay.
The beginning.
So, can you see this? Can you hear me now?
Yes.
Yes. Yes?
Yes.
So this is a photogrammetry, is a picture that...
No, Paolo.
Yes?
Sì. Quando siamo stati qui in Yemen,
Okay.
si foto anche con il professore in
Yes.
ricordi?
Okay.
Sì. We want to see because before we couldn't see it.
Okay. This? Can you see?
Okay, which slide do you want, Mohammed?
Yes, yes. Because we were with the professor 6 years there, and at the beginning he showed us that photos, but we couldn't see it here with our colleagues. Well, all of it, yes.
Can you see this?
Here, yes, we couldn't see it, but I think now in our data show, we have
Io però, scusa, io I'm sharing the... No?
Okay, okay. Thank you very much. Now for this section discussion. Any question for Professor Paolo? Yes.
I just want to... Hello. How are you? Hello.
Go ahead, Victor.
Yeah, hello. I just want to congratulate Dr. Paolo Perrini. A very nice lecture, very nice pictures, and correlation with surgical cases was very useful. Thank you so much.
Thank you very much. Thank you, Victor.
We still one question from our colleague here, Dr. Mohammed Al-Khayshani. Just a minute, please. Just a minute.
Okay. It's coming to the microphone, right? Okay.
My question, you can listen to me?
Yes.
You can, okay. So in one slide, we saw a very big tumor involving the whole area around the left middle cerebral artery.
Yeah.
And you said at that time that we can't remove the whole tumor.
Yeah.
So from your point of view or from your angle, what is the best approach for such tumor? To remove the periphery and leave the center of the tumor, or to leave the whole tumor? I hope you get my idea.
So for the main problem is the tumor if is on the dominant or non-dominant side. It's quite different. However, today the best approach should be with the awake patient. So if you have the patient awake, you can You can map the brain also for the speech, so you can understand where you are. There are a lot of anatomical landmarks, but for insular gliomas, sometimes are not enough, especially about the language, okay? And the other problem is the anterior peripheral substance. Also in a weak patient, you cannot remove lesions that are going in the anterior peripheral region, and because you will cause invariably hemiplegia, okay? So you should try to map the brain.
The main problem with such tumors is the vascularity. For example, you are approaching the tumor, you will surprise, any blood vessel can surprise you at any time. It is just blood, vessels in bus feeding another area, so you can harm it even in a weak patient. This is what I mean.
To the vasculature, yes, it's very important. Yeah.
Yeah, but even a weak craniotomy, it will not protect you.
No, but depends how you go through the tumor. If you go subpial, you can remove a lot of tumor without encountering a lot of vessels. Depends how is your technique. You can do transsylvial or transopercular. It depends how you go to the tumor. Transsylvial, you can dissect all the vessels, but the small vessels sometimes are very difficult to dissect. If you go transopercular, you don't see a lot of vessels. You can remove, there are a lot of papers about this topic. It's quite complex topic. No, we should discuss with some clinical case also. But these are the two techniques with different pros and cons.
Thank you.
Okay, Ahmed. Okay, we're going to continue on here, Ahmed. Okay.
Okay. Next presentation, microvascular decompressions and radio frequency for the management of trigeminal neuralgia, cooperative study by Dr. Abdulghani Nasher.
I'm Dr. Abdulghani Nasher, neurosurgery consultant in Police Typical Hospital. I would like today to talk about trigeminal nerve and trigeminal neuralgia and the management of trigeminal neuralgia. My study about microvascular decompression, comparison study between it and radio frequency. trigeminal neuralgia اللي هي التهاب العصب الخامس، هذا مشكلة تخص أطباء الأسنان، أطباء المخ والأعصاب، أطباء جراحة المخ والأعصاب. trigeminal neuralgia also called dolorous disorder affecting the trigeminal nerve, causing severe shocking pain, electric-like pain, unbearable in some patients, and they cannot sleep, they cannot talk, they cannot taste anything. The history about this started by Sandro, who then Bill described the anatomy of the fifth nerve. Dandy, who is first who described the problem, vascular compression. Then carbamazepine using and phenytoin and pregabalin. The anatomy of the trigeminal nerve origin from the upper ventral bones, has 4 nucleus and 3 branches. A distribution of the trigeminal nerve, as you see in the photo. Epidemiology annual 4 to 5 per 100,000. Gender, female more than male by the double number. Pathophysiology, it is compression of the trigeminal nerve by the vascular compression, mostly superior cerebellar artery, then posterior fossa tumor or cyst, then multiple sclerosis. It irritates the trigeminal nucleus and cause attacks of the neuralgia. Evaluation, good history taking and good examination. MRI used to evaluate and exclude other pathologies. Medical treatment is the first and the golden choice for any doctor, neurosurgeon or neurology to treat this problem. We start by the carbamazepine, tegretol,
complete relief reach 70%. Side effects sometimes make some patients cannot tolerate this drug. At doses, as you see, aloxcarbazepine is rapidly metabolized than carbazepine, with side effect less than carbazepine. Then baclofen and gabapentin. If the medical treatment failed and the patient has refractory pain not responding to the medical treatment, we consider surgical treatment. Options, first one is microvascular decompression. Second one is minimally invasive procedures, percutaneous rhizotomy, include the radiofrequency, glycerol injection, wall Fogarty catheter ballooning, injection of sterile boiling water. And the last one, which is not available in our country, is stereotactic radiosurgery. Aim of our study is to compare clinical outcome and economic effectiveness of microvascular decompression and radiofrequency in the treatment of trigeminal neuralgia, according to our study and international meta-analysis. الماتريال احنا بدأنا في المايكروفاسكولار decompression from 2016 to 2020. The general number is 30 patients. 7 of them have underwent microvascular decompression, and 23 of them treated by trigeminal radiofrequency ablation. Little point about microvascular decompression, craniotomy, l'approach as you see here, retrosigmoidal approach, position as you see. Then the goal of this procedure is decompress the vascular structure, decompress the trigeminal nerve from the vascular structure, either by use Teflon or we are using muscle to decompress the trigeminal nerve. Trigeminal nerve could be compressed by the trigeminal vein, by superior petrosal vein, and by superior cerebellar artery. In general, mortality for the microvascular decompression doesn't reach 1%. The incidence of aseptic meningitis could reach 20%. A major neurological deficit from 1 to 10%. The failure rate reached 20 to 25. Another option was percutaneous trigeminal radiofrequency. We are recommending this procedure for patients who has poor general condition, who wants to avoid surgery, who has unresectable tumor, or who have multiple sclerosis. This procedure, insertion of the trigeminal of the needle, radiofrequency needle, we are doing it as a day case procedure. The patient will not be admitted. He will not undergo general anesthesia. Within 15 to 30 minutes, the procedure can be done. I am using sometimes neuro navigation to determine the foramen ovale and the insertion of the needle and start the procedure. A complication, dysesthesiasis, minor in 9% والميجر in 2%. أسوأ حاجة اللي بنواجهها هي الأنستيزيا دولوروزا 4%. The patient feel burning, itching pain at the site of surgery. Meningitis doesn't reach 1%. A result of our study, 7 patients was operated by microvascular decompression. 1 of them did not improve. Then we have done for him radiofrequency. From the 23 patients treated by radiofrequency, 2 patients also hasn't improved. Limitation of our study that the follow-up still only not more 14 months. So we need time to make more evaluation. A conclusion, microvascular decompression and the radiofrequency, both satisfactory treatment for patients who has trigeminal neuralgia. From our analysis, microvascular and MVD and RF has similar pain relief. But some elderly patients may be not suitable for this type of surgery in microvascular compression, so we are advising and recommending radio frequency. The total cost of MVD are much more than radio frequency. Radio frequency less expensive. Here I show you some international opinions and papers. Take-home message: medical therapy remains first line in treatment of trigeminal neuralgia. Surgery and interventional pain treatment can be considered in patients who have persistent pain despite drug therapy or who are unable to tolerate adverse effects of the drug. Microvascular decompression had a lower risk of requiring a secondary procedure and facial numbness after surgery. A radio frequency could be considered in a patient who are unfit for microvascular decompression or refused invasive treatment. Thank you very much. Question?
Thank you, Dr. Abdullani. Many questions before the lunch, huh? Quick, lunch time.
Lunch time.
يلا.
شكرا جزيلا دكتور عبد الغني على هذه thank you for this lecture. My question is, you remember here that the first line for trigeminal is the medical treatment. What are the criteria of indication for operation? Criteria of indication of operation for trigeminal neurology.
As I said, the indication of surgery is in patients who cannot tolerate the side effect of drugs. As you know, all of these drugs I show you, it is anti-epileptic drug. All of them can cause drowsiness, nausea, and sleep disorders. Not everyone can tolerate the side effect. The other indication, when you are using the maximum dose of carbamazepine or other drugs, and there is no effect. The patient is still crying and crying from the pain. He doesn't find any kind of management to help him. Unfortunately, some of patients can make suicidal end of his life. So the microvascular decompression and the radiofrequency and other procedure solve those problem probably.
Okay, the maximum dose of carbamazepine, how much? And in the study, there is comparison between pregabalin and duloxetine with carbamazepine.
As a doctor, you can
in the
use
study, if you have study cases treated by pregabalin or duloxetine.
You mean a combination of medical treatment?
Yes, combinations or one drug alone.
You know, the combination of medical treatment, the best combination is between
the maximum dose of carbamazepine.
Gambabintin.
I can
1200.
بالنسبه للجابابنتين احنا قلنا انه الماكسيمم دوز از 1200 ملي جرام. بالنسبه للكاربامازepine to 3600. But you can combine some medical treatments. So you can combine baclofen and carbamazepine or carbamazepine with gabapentin or pregabalin. It also could have a good effect.
Okay, thank you, Doctor.
Doctor, what about amitriptyline?
Amitriptyline, yes, it is one of treatment of chronic pain at all, especially in headache, a patient who has a chronic headache or has chronic pain at all. But also it has the third class of management.
But could we make it combination with carbamazepine? amitriptyline with
If
carbamazepine.
patient can tolerate this, yes, why not? But the problem that combination of amitriptyline with another anti-epileptic drug sometimes unrelatable.
Is there any rule for concentrated alcohol for local injection?
Role of what?
Concentrated alcohol for local injection.
Alcohol was the first line of treatment before producing the radio frequency and Fogarty balloon. Alcohol was, but its side effect was very irritable. Yes.
Question, Dr. Muhammad, for your question, associated between amitriptyline and carbamazepine, it is same group statistically. You can do associated. Only you can carbamazepine for another drug. Maybe duloxetine is the new drug for this for neuropathy.
With the citalopram, and can we do it? Citalopram with carbamazepine. Citalopram. Citalopram. Yes.
Yes. Why not?
Okay. Yes, doctor.
So can I have a question?
حالات يا دكتور حق الراديو فريكونسي معنا احنا بالس راديو فريكونسي ومعنا هيت اللي استخدمته انت الهيت كونتينيوس ولا البلس؟
In our study we used only the Legioning.
الحراره كم؟ يعني
up to 70 from 68 to 70 degrees.
ايوه خير ان شاء الله. الان الجايد لاين هو الان يؤكد على البلس ثيرابي لانه
there is a new direction but still
الهيت ليجن اكثر من 60 الان بتعمل لنا ديستراكشن للنيرف تمام. فاقصد انه يعني الان اللي عملناها الان المضاعفات اللي حصلناها ممكن نتفاداها في البلس فريكونسي. كل المضاعفات اللي ذكرتها اصلا مش موجوده في البلس فريكونسي.
Yes, now there is a lot of studies starting to use pulsed radio frequency for those who doesn't know what it means different legioning. It means coagulation. It make burning. It make heat by thermocoagulation. But pulse just make pulse of radio frequency and doesn't make any injury of the trigeminal nerve.
الحاجه الثانيه النقطه حق الكاربامازepine والمسمه. اغلب الناس الان اللي يخرجوا من المانجمنت حق الفارماكولوجي في الكاربامازepine والانتي ديبريسانس والجابابنتين والبرجابلين السايد افكتس حقهم اذا تابعت المرضى غالبا دائما يدخلوا في مضاعفات مبكره وهذا اللي يرجعهم مستقيم باتجاه في ادويه الان جديده دخلت في السوق لكن عادة ما وصلت عندنا. لكن غالبا الدوز اللي ذكره الدكتور مش هاي دوز اللي يخرج المرضى من الان من المتابعه السايد افكتس. هذا اللي
دكتور محمد الخشني.
Yes.
Yeah, last track.
Many questions.
Hello.
Thank you very much. First, trigeminal neuralgia, first branch distribution. Can you use radio frequency ablation?
No, we cannot use the trigeminal radio frequency rhizotomy for the first for ophthalmic branch because it could lead to corneal ulcer. So in our study, we treated the patients. Even if he has 3 branches, we are considered only for the maxillary and mandibular branches.
Okay. Aseptic meningitis. You said the percentage is 20%. Okay. If you use muscle instead of Teflon, still the percentage will be the same.
Well, in Yemen, me and all of our colleagues, even our teachers, they are using muscles.
So the source of aseptic meningitis is Teflon.
Could be maybe like, but Teflon also is a foreign body, so it's.
I mean, without it, there is no percentage like this.
Yes.
Thank you very much.
Thank you very much, and we want to thank our colleagues from outside, Professor Paolo Perrini from Italy, and Professor Sharian from Brazil. Thank you very much for them. And now we want to invite them for lunch. Our colleagues from outside, but we can. Okay, we want to tell about. We will start our third session at 3:30, and we want to tell there is في جوائز يعني في جوائز بتكون بالسيشن الثالثة تمام اللي تبدأ الساعة 3:30 لذا يعني بننصح انه البقاء
في سحب على لابتوب
يعني أيوه.
سحب على هدايا لابتوب
تمام. ونبارك للي بيكون محظوظ.
يلا
Okay, very good. We stopped recording. Are you there, Ahmed?
So, Mr. John, Johan.
Yeah, I can hear you, Ahmed. We stopped recording, but we're still on YouTube.